Well, good morning, everybody. I'm happy to be here to have an opportunity to share eBroselow with you. We're very excited about a new technology, and it's part of a long process. I want to give you a little bit of a historical background. I don't know, different parts of the world are more familiar with eBroselow and the Broselow name than others. But this whole concept of medication safety and standardization started back in the 1980s. And Dr. Jim Broselow was a family doc who started working in ERs, switched to full-time emergency medicine, and realized that there were real problems in community hospitals dealing with children in emergencies. They came in, everybody was nervous. What's the dose? How much does a child weigh? You were given medicines that you hardly ever gave. The formula sounded similar, milligrams, and once you figured out the milligrams and the theoretical weight, you had to figure out how many mils and what was in the vial and how do you convert it and how fast do you give it. And these were all drugs that you gave to adults every day. And at the meantime, you're looking at a bad child and thinking, gee, that reminds me of my niece or nephew or even my child or grandchild. Very anxiety-producing. So he came up with a simple solution, which was to use the length of the child. And he developed a tape measure. When you measure the kid, you didn't get how long they were, you got how much medicine they needed. So this is kind of a graphic that shows the whole system that developed. You can see a child that's being measured. You see how long they are, and each of those little rectangles represent the exact dose for that child of every medicine in milligrams. It started out with a few meds, but ultimately had rapid sequence intubation and seizure meds and pretty much everything used acutely. He started working with Dr. Luton at the University of Florida, and they realized that equipment was one of the critical things for children. So they did studies in the operating room and showed that how long a child is would determine their critical equipment. So the tape expanded. It had not just drug doses, but it had equipment. It got very busy. The writing got smaller. There was more and more information. The decimal points got smaller. The nurses got older. And so ultimately, they decided to color-code it. Once they color-coded it, you could measure a child. If they were red, you could open the red drawer of the crash cart or open the red bag, and it had virtually every piece of equipment specific for that child. So this was an idea that developed in a rural area, but it quickly became standard of care within the United States. Pretty much every hospital in the U.S. uses the tape and color-coded crash carts, and it's been used internationally as well. So this was a solution. It was really one of the first lean solutions in clinical medicine. We think it probably was the first. You can't get a lot more lean than measuring a child and just getting their color and giving them the purple dose and the purple equipment. And it did solve a problem, but Dr. Broselow, working with Dr. Luton, realized this was a small part of the larger problems in medication safety. And so they spent years trying to expand this and went from a paper system to trying to take advantage of modern technology, and ultimately developed a system called eBroselow, which we're going to show you today. It's really aimed at the bedside nurse or doctor or pharmacist, and its goal is to eliminate human error in medication calculation administration. It's not brand new. It's in about 300 hospitals in the U.S., and basically, it's web-based. You click on a link and the system comes up, and we're going to show it to you in a little bit. But one of the first things I wanted to share with you is the thoughts of Dr. Broselow and our company is, yes, this tape and color-coded system helped, but there's still much more work to be done. And so these are just a few headlines. These are in the U.S., but of course they've occurred internationally as well. And it's about mistakes particular to children. This was a children's hospital, and a child died of a 10-fold overdose, accidental miscalculation. Prominent children's hospital. One of the saddest part of this, and we all think about it, is not just the family, it's not just the patient, but it's the hospital reputation, and what it does to the healthcare providers that got involved. This was tragic. The actual nurse that committed the error ended up taking her own life, and she was an experienced pediatric ICU nurse, and it's just tragic that she took all the responsibilities upon herself. There are other examples of this. You may not know Dennis Quaid, but in the U.S. he was a very famous actor. He had probably one of the most prominent twins ever born in the U.S. It had all kinds of publicity. He was in one of the best hospitals in the U.S., and somehow they managed to give a 1,000-time overdose to his twins. And so it's just pretty incredible that a patient and a family like this that had so much attention could have an error like this. This is another children's hospital. Again, tenfold error there. This was a hospital in Florida. A 3-year-old boy died. 3 children in Indiana hospital. And the headline from this newspaper kind of sums it up. This is a system failure. And so we realize that the systems to give safe medications just are not up to the job. And so a lot of what we've done as a company is to try to address these really important issues. There's probably nothing summarizes it better in children than this decimal point, and as it expands, we see the problem death by decimal point. That is really particularly what we want to eliminate in children. Now, I just want you to stop and look at this slide. Do you think this is a problem? Yeah, I'll bet you do. I mean, as soon as you look at that, you realize, holy cow, what are the chances that every single thing there is correct? In fact, how could you ever get all of that correct? The mixing, the instructions, the math, the calculations, setting the pump, knowing the side effects. It's pretty much impossible. Why don't we know that this happens and errors happen every day? Perhaps it's saving grace for us that we don't recognize these errors. When a nurse or a pharmacist mixes a drug wrong, calculates the mils wrong, gives it at the wrong rate, doesn't know the proper guidelines, when we get to the documentation part, we simply say we gave exactly what the doctor ordered. In other words, this is the area where we are really addressing errors that depend on human capabilities that really cannot be done. And so this is the essence of what eBroselow addresses. Here's my question. What is the root cause analysis of errors of this type? It's humans being dependent on math and memorization to do life-saving administration of drugs. It's basically impossible with our present systems. So here's a book, and you guys are used to looking at medical books, but this is interesting. It's actually an engineering book, and they're talking about humans, you know, like all of us in the room. And so they studied human error when it comes to mathematics. And they found that under normal conditions, there's about a 3% error. Even when people second check somebody's math, it's consistently about a 10% error. But the most startling is that under stress, the error rate for humans is 25%. And you look at that picture on the right, I don't think there's many things more stressful than trying to take care of an unstable, perhaps dying child that is your sole responsibility is to try to save them, and you may not feel up to the job. You may not feel adequately trained or adequately armed to do this. We started out looking at weight-based dosing in children because we realized early on that that's one of the things that confounds pediatric dosing. But through the years, as we've developed the system and expanded to adults, one of the main reasons we did it is we realized that weight-based dosing and indication-based dosing, once kind of the purview of pediatrics, is now done every day in critical care in adults. Anticoagulants, antihypertensive drugs, infusions, all these drugs have become progressively more complex. The standard of care, unfortunately, in the United States right now and internationally, is to do math on a bed sheet. And this is an example on the left. I think this was on actually a paper towel. But it shows a pretty startling approach to trying to save somebody's life. Now, I want to talk specifically about medication errors because I don't really think that they're on people's radar screen. I want to talk about a math error, but in a different context. So I want you to use your imagination. I was an ER doc, and, I could see myself walking into a room with a young lady whose father has just had a stroke. And I want to give them a medicine. And I explained to the patient's daughter, because the patient can't talk right now, that there's a medicine recently developed that we can give to try to break the clot apart. And if it's successful, we may be able to reverse your dad's stroke. But I have to tell you that there's a risk. And the risk is about 5% of the time, this may actually cause a bleeding in the brain, which very much could be fatal. So we're taking a risk if we give this medicine, but we do know that there's about a 30% chance it will clear the stroke. So the young lady says, look, I know my dad, he's been active all his life, he would want to go for it. Let's go for it. Let's do the med. And so you give this medicine, and unfortunately, the patient has a stroke and has a bleed. And now you are faced with walking back into this room and talking to this daughter again. And you say in a compassionate way, because you're feeling the same feeling she is, you've gotten involved with their care. Your father bled, but we know he would have taken the risk. See, we think he was one of the 5%, and that's why he bled. But how about if he had been the 95% that would not have bled, except we gave the medicine wrong? We gave it too fast. We didn't mix it correctly. How in the world is a doctor, a nurse, or a patient supposed to know that the risk, which was unrecognized, is really the reason that the father died? Or conversely, if the stroke didn't clear, we would say, well, I'm sorry we took that risk and he got the medicine, but sadly he's in that 70% that doesn't get better. But we don't know that. He could very well have been in the 30%. He was there early, but you didn't give the medicine right. You mixed it wrong. You gave it too slow. So what I'm trying to point out is it's almost impossible to tell the difference between medication errors and the course of diseases. And that's why this is such an important issue that we have to bring to the forefront. People need to realize that medication errors occur much more frequent than we know. They probably have a lot more serious effects than we're aware of. And so since we don't detect these, what we need to do is prevent them in the first place. And that is really the whole reason eBroselow was developed. So I don't know if any of you have, what are your thoughts about this? Do you think that you could have walked into a room with a similar situation? Do any of you feel that you've probably made mistakes and thought it was just the patient not getting better and didn't realize it was our team, it was our pharmacist, it was the fact that we were stressed or interrupted, or it was the middle of the night? Yeah, I thought you would. I mean, I feel this way, and I think the more people that we've spoken to, continuously start to realize that these are real problems. They're not theoretical problems. So, I've been talking in a vacuum. I really haven't shown you eBroselow or what it represents. So I want to show it to you now. And I'm going to pull up eBroselow, and it's basically a web link. And so let me find on the screen here. And so this, and I want to make this a little bit larger now so that you can see. And so what you're looking at is exactly what would appear on a screen with eBroselow if it were just a web link. What I've done is I have clicked on a link, and this would be basically in every computer in your hospital or in your ED, and you would not need a password. We recognize the hospital, so any computer in the hospital can visualize this. And again, I know you've not seen it before, but I want to point out that we have weights here. I've started with adults just to emphasize, and I'll show this later, that we started with children, but we have everything for adults as well. So you can see that there's a search box here, so I could type in the name of a medicine, and or I can find a medicine alphabetically. And by the way, just stop and take a look at this. I have an adult weight here, and these are all the drugs in this system, and these are just the A's. just the A's. So if you think that we're talking about just pediatric emergencies, you'll see that we have just about everything. Antibiotics and seizure medicines and oral medicines. Pretty much any drug that you would give a patient in a hospital is in this system. Because we started with kids, I want to check the smaller kilogram and show you what the pediatric face looks like. You can see that you could select a weight, 4 kilograms or 10 to 11. Or if you were using a Broselow tape and they were purple, you can select the color. So here's a purple child. So what this does is it sets the system for this color or this weight. So I mentioned that you could look for drugs in multiple ways, but one way is by category. So the first category, and you would figure this out probably, is resuscitation. So I've gone into the resuscitation section to show you the choices, and it's interesting just to see how many meds are involved. And what I want to do is I want to take a simple medicine like adenosine that we've given, and I want to show you how it works in eBroselow. So I'm going to click here where it says adenosine supraventricular tachycardia, and I've come up with a page. Now, I know you haven't seen this page before. It is probably going to look pretty busy to you, but I want to explain exactly what we tried to do before we go through this page. You know, I'm sure you're all aware of encyclopedic type references, and if you look up a medicine in the encyclopedia, it could have, you know, the chemical formula for it. It could have, you know, every side effect you can think of, including minor rashes, and it has a huge amount of information. That's why it's an encyclopedia. Well, the encyclopedias were books, and now they've become electronic books. So you can click on it, but you still basically get an encyclopedia. Imagine if you took that encyclopedia and you took the information and put it in a database so that you could draw on whatever information you needed to treat a child at the bedside. What exactly would you want? Well, what I would want is the drug name and indication. I would like to be able to pick an exact weight if I wanted it. I would want the dose of milligrams. I would not want to have to calculate the mils because there are errors there. So I would want that pre-calculated. I would want to know how fast to give the medicine. I would want to know the side effects and the warnings and the compatibilities. And wouldn't it be nice if that was on a single page? So that's how eBroselow works. For every single drug, you can just select the drug and the indication. Let's give you another example. This is a drug we don't use a lot, but you could easily make a mistake. This is mag sulfate, 10 kilogram child. So not only do we give you the doses, we show you exactly how to dilute them correctly. So if you already have the med ready, you can see that the dose was 500 milligrams, that you need the 40 milligram per mil, and the dose in mils is 12.5 mils. Now, if you didn't have it prepared and you didn't have a pharmacist, the tool here helps you make the right concentration because it comes in 500 milligram per mil vial. Now, this is not something that doctors think about, but certainly nurses think about it all the time. How am I supposed to get this into the right concentration to give it to the child? Well, this is a tool that does it for you. It tells you how many mils to put in how many mils to make the 12.5, which is your dose in mils. Then I would want to know, how do I give it? Well, it matters what you're giving it for. If you're giving it for a cardiac arrest from torsades, you push it. If you have a pulse, you're allowed to take up to 20 minutes. Asthma up to 30 minutes, or low magnesium even 2 hours. Do you all agree that if I was treating a child with low magnesium and I pushed the medicine, that that's an error? Yeah, it is an error, isn't it? Because you've subjected that patient to an unnecessary risk. Whenever you push a high dose, you take a risk that they're going to have a more serious side effects. So we give you the milligrams, the mils, how fast you give it, the adverse reactions, what to look for, and your compatibilities. We call this a V-page or virtual page because it's not a real page in the book, but the way you get it is you enter data. You enter a weight or color on the tape, you enter a drug, and you pick an indication. Let me give you another example about indication, which I think really shows another exciting part of our system. I'm going to type in a drug that you've given a lot called Decadron. And first of all, I want you to look over here. Don't cheat and look at the left. No, no, no. Don't look here. Look over here. That's right. When you look to the right, you see all these numbers? I mean, nobody is going to memorize all these numbers. What do they tell you about the real world? Very, very little. But if you look to the left, you say, gee, airway edema, that's what the 0.25 milligram per kilogram means. If I'm treating a swollen brain, it's 1 milligram per kilogram. If I have croup, it's 0.5. So what we did is we tried to associate the dose with words. In other words, people understand words and can communicate. So let me give you an example. I have put in a theoretical weight here, and let's say I have a child with cerebral edema. Once I've entered the data, I can click on the link. I can enter an exact weight, and I can look at the vial that I have, and it's 10 milligram per mil, and that gives me the mils. So it gives me the weight in milligrams for that indication, the mils, how fast you give it, the dilution, and the side effects. Now, I want to show you an additional feature which I think is really nice. If a doctor comes in the room and say they order Decadron 15 milligrams or say 12 milligrams, you can see from here that if you had the 10 milligram per mil, the dose would be the standard dose in eBroselow would be 1 mil. If the doctor ordered 12, it recalculates it, and it tells you that the doctor has ordered 1.2 mils. But importantly, it has shown you the variance up here. So what this means is that anytime a nurse is giving medicine, if they want to check it for that drug and indication and weight, they can immediately see if there's a variance from a standard and how big the standard is. It allows you to have maybe a typical protocol in the ED that, for instance, I don't care if you're a first-year nurse and you have the head of the department, they're ordering a medicine. If it's, say, more than 30% variance, you're supposed to ask that doctor why it's a variance. And they may very well have a good reason. They may say, well, this patient, I know them and they're less tolerant, they're less responsive to meds. Or most likely they'll say, oh my goodness, thank you. I was thinking of Decadron, but I was thinking of the croup dose, and this is a different one. Thanks for pointing that out. This is an example of how a system like this can help everybody in the room. And basically it does help everybody, because when we went back, the physician that had to order had to figure out how to give this medicine for cerebral edema. And if they hadn't memorized it, this helps them because they can see the cerebral edema dose is going to be 10.5 milligrams. So they order the correct dose in the system. When they order the correct dose, then you don't have to change the variance because it exactly matches. So it helps them do indication-based dosing. It helps you check the dosing. And it gives you the instructions you need to feel confident that you gave it correctly. I'm going to give one other example for children here, which I think is one of the really strong points of our system. And let's pretend that we had a child that needed an infusion for an emergency. Say they were septic. Now, again, I know this is a different look, so it might take you a second or two to get used to what you're looking at. But basically, for an infusion, you can click an exact weight, even down to 9.8 kilograms. We tell you what is the right concentration for that weight. You may not have thought about this before, but when you mix an infusion in child, the dilution, what concentration you pick, totally depends on how big the child is. If you get it wrong, you can't give the smallest dose because it's smaller than your pump will give. If you have the wrong concentration, you could drown the child because you're giving too much fluid. So one thing eBroselow does is it picks the exact concentration for the weight. Then, because you're going to have to mix this drug is not stored or usually sold mixed, you have to know, how do you make this correct concentration? Well, we automate that for you. We tell you that you can put 13.2 mils in 250. Or if you say, I want the final volume to be 100, you can just change that to 100, and now it's recalculated for you. You would be 5 in 95. The next thing you need to know is, how do I set a pump? Well, as a physician, if I haven't given a lot of epinephrine, I like looking at this because it tells me the range for my order. So I'll say, well, I'm going to start 0.25 mics. As a nurse, what I like is it tells me that the pump is going to be 2.9 mils an hour. The reason I know that is I know how it was mixed. So now I can easily follow the doctor's orders by just adjusting the pump, even if I don't have one of these, quote, smart pumps with libraries. If I have a smart pump, this helps me check the library to make it correct. Again, it's not just the dose, but how do I give this? Do I start high and I go down slowly? Do I start small? How long do I wait between changing the drug? All these guidelines are drug-specific and sometimes indication-specific. So we give you the guidelines, we give you the warnings, and really importantly is we give you the Y-site compatibilities. So again, this is exactly what every member of the team needs to know how to mix, how to administer, and how to monitor for side effects. So anyway, I don't have, there's questions. That's a lot to show to you. And we have many, many things over here that you wouldn't have guessed. I'll just show you quickly for children. This is prescribing by indication. If I wanted to write a prescription for amoxicillin high dose, holy cow, that's exactly how I write the prescription. 6.5 mils of the 400 milligram per mil, and I'm going to give it Q12 hours. So I've nailed that. In other words, eBroselow is not an encyclopedia. It's granular. It shows you exactly how you write things. Even with common prescriptions, it reduces errors, certainly saves a lot of time. Another example of what we do, which is exciting, is in emergency medicine, burns in children are incredibly complex. If you had a 5-kilogram child, you need to know their exact body surface area and how many hours after the burn to pick out their particular fluids. We've automated the whole process. If this child had 100% burn on their head and they had an 80% burn on their chest, and say on the back it was 70%, and we total the burn. You see what we've done? We say with these percentages of this body, it's 29%. But then we calculate the fluids according to how many hours post-burn. So because you have to catch up by 8 hours, so if a child comes in 2 hours post-burn, basically this tells you that you're going to give 36 mils per hour of Ringer's lactate. This bottom part is maintenance fluid, and this is called a Galveston formula. They figured out that for young children, it's even more exact if you include maintenance fluids. You don't have to do that for adults. So we automate that for you. So this child at 2 hours, we tell you how much maintenance fluids along with Ringer's lactate. We show you urine output. And this whole thing could be printed and sent with the patient that had a burn. I'm going to show you one or two things quickly with adults just to show you again that we're a very comprehensive system. And I can go into categories here. And let's say that you had a hypertensive patient. It shows you all the oral medicine, the IV medicines, the infusions. And again, it's the same format. If you were giving nitrite to an adult, it shows you how to set an exact weight for the adult, how to mix it, how to set the pump, side effects, etc. So going back to our original slide here, I just want to show you how comprehensive this system is. We have everything. We have antibiotics, we have fluids for adults and children, and basically this is a systematic approach to medication safety that we feel very strongly addresses these issues that I mentioned before. The last thing I'm going to do is to go back to my slide presentation and pull that back up, and I just want to finish with a couple slides and then try to answer questions. You may say, this makes a lot of sense to me, but is there any evidence of this? How do we know this works? How do we know that your system isn't going to introduce errors? So this is a very important study. This was at the University of Kentucky. It was in their School of Pharmacy, and it's what's called a simulation study. Although they didn't have real patients, they videotaped every part of this. And basically, it was a simple study. They took ED nurses. They were looking at eBroselow and its barcoding capabilities. And so they had 130 doses to give to children. They were being observed, and they used all their children's hospital and university tools that they had. They had spreadsheets, they had pocket guides, and they had calculators. And then they gave these doses to the children, and the error rate was pretty phenomenally high. 17% of all drugs administered had errors, and amazingly, 7% had errors that were at least 50%, up to 900%. Think about that, 7% when these nurses were using their own tools, the error was at least 50%. And, I ask you, what do you think this nurse would have written at the bedside if they'd made those mistakes? They would have written that they gave the right dose. So these are unrecognized errors. None of those nurses knew they were making a mistake when they were observed. They used our system, and in the U.S., the medications come with barcodes on them. So this particular study used a barcode reader to scan the vials. And so the nurses just picked up a vial and scanned it, and what that did was calculate the dose in mils along with getting the correct drug. And the rest of the system was just like I showed it to you. Basically, out of 130 errors, there were no significant errors, none. And the amazing thing is these nurses had never seen this before. This was just about 10 minutes of training, and it shouldn't surprise us because we see this every day at the supermarket. We know that the checkout counter ladies don't have a lot of training, and they immediately do math for multiple products, all on sale and different pricing and combinations. And how do they get it right? Well, they scan. And so one of the upper level parts of eBroselow that will develop more and more internationally is the ability to scan meds and eliminate the human errors of math and memorization. One last study is an important one. This was in the British Medical Journal of Quality and Safety. And what they did was this was an observational study. And an observational study means somebody sat there and watched these medicines being given, and notice this was almost 600 doses, 6 wards, 2 teaching hospitals. And this was not in the emergency department. This was not under stress. And what they did is they checked the errors, and this is what they found. There were multiple errors. The errors turned out to be about 99 errors out of 600. And they had 2 classifications, but the serious errors here were 95% were in were wrong rate errors. Remember, our system totally calculates the rate for every indication. Wrong volume errors, you don't have to calculate volume. Mixture, we automate mixture. Compatibilities, we have it with every drug. So of all the errors that they considered serious, eBroselow would have eliminated those errors. So there's several studies showing that this is not just theoretical. This is real, but even intuitively, all of us know that we're human. Nobody can get the math right all the time. And so you have to accept that this is happening every day. The key to eBroselow is it's a simple, inexpensive, scalable solution. We are now integrated in Cerner, and we're integrated into Epic in the U.S. So in integrated systems, you don't even have to put the weight in. You just right-click, and this is what comes up. So we look at eBroselow as a way of getting knowledge at the bedside. And the knowledge could be numbers, or the knowledge could be how to give a med safely. But the bottom line is with eBroselow, 1 or 2 clicks away, and you have the knowledge, to give a medicine safely every time, eliminating the need for math or memorization. And if you have a scanning system, the safety knowledge is just one scan away. So one click away, one scan away, and pretty much you eliminate human error in acute medication administration. So I know that's a lot to show you in a short period of time, and I know I probably went through things quickly, and I'm sure you have questions. So I'd like to answer your questions now or concerns, and see what you have to say. Well, thank you very much. I want to ask you a question. Can any of you think of a reason why you would not want to do this? Yeah, that's always a question, right? How much does it cost? Well, our goal as a company is not to be expensive for an individual hospital. Sure, we have cost. I mean, we have to cover cost. You don't want it to be free because you know if it was free, suddenly it wouldn't be there in a couple of years. So we have to have enough cost in the system to protect it and allow it to grow and allow it to be safe. But on the other hand, our goal or mission is to make this available for everybody. So we price the system to make sure that pretty much any hospital can afford it. Without getting into the real details of that, let's kind of look first of all at the need and see if you agree that how many of you think that this would help you? And why do you think that would help you? Yeah, that's right. And do you have questions? Well, sure. Okay, well, hopefully I've answered your questions, and what we want to do is give you more familiarity. We can make this available to you to look at if you have questions, but do any of you have suggestions about what we would need to do to take this to the next level? Is there anybody here that maybe would like to help be a spokesperson for us, help us communicate to your administration people? Sure, they're going to want to know how does it work with computer systems, when is it updated? There's many issues to this that people will want to know before they're comfortable. But we feel like we have good answers to those questions. We're in a bunch of hospitals now. We've been up and running for a number of years. We've had a huge amount of feedback from really sophisticated hospitals, and our goal is really to disseminate this and to help protect patients everywhere. Thank you so much.